Hi, it's Dr. Centeno, and this is level 2 hand. We're going to go over CMC intra-articular ligaments and median and radial nerve blocks. As usual, this is an online course meant to be paired with a hands-on cadaver portion and written exam. So don't attempt these procedures until you've been certified by an IOF instructor. Focus here is treating hand CMC arthritis that's mild, moderate to early severe. And PRP and platelet lysate for most patients. Some will require bone marrow concentrate due to severity, but PRP works surprisingly well here in about 80% of cases, even much better than in knee osteoarthritis, where PRP really can't tackle moderate to severe OA, or at least it does a poor job. With very short-term results. Here you get much longer-term results because your focus is as much on changing the or as much on changing the microenvironment of the joint as it is on the capsular ligaments. CMC treatment protocol. We're going to focus here on median and radial nerve blocks for this procedure. CMC capsule and Ligs with low dose, preferably leukocyte poor PRP. CMC intra-articular with high dose, preferably leukocyte poor PRP. So median and radial nerve blocks. So median nerve anatomy on the wrist. The nerve is fairly superficial. It's actually surprisingly superficial. You can see it right up here. It lives right underneath the transverse carpal ligament and amongst the flexor tendons. Our nerve block here is going to focus in giving us anesthesia in this portion of the palmar aspect of the thenar eminence of the thumb. And in normal ultrasound anatomy, you've got the tendons that tend to be hyperechoic, and you've got the nerve that tends to be hypoechoic. If you're really got good imaging on the nerve, you're going to see this honeycomb type classic appearance. So it's easy to get confused as to what is and what is not the median nerve. This is a small format high frequency linear probe. I'm starting here at the distal wrist crease and moving the probe proximal and distal. I've put a little arrow on the nerve, so I'm going to show you a little video here where you can watch me follow the nerve. And so as I come more proximally, the nerve's going to dive down. As I come more superficially, the nerve's going to come back up. And it's got that honeycomb appearance. And our focus here, again, is on this video, taking just a minute or two and identifying where that nerve is. So you can see the nerve diving down here as I come proximally, and the nerve coming back up as I go distally. And our focus here is getting the nerve right up to the perineurium. Getting the needle right in here and injecting some fluid, and not injecting into the perineurium, but injecting around the perineurium and haloing that nerve. So it's important to understand that some of these CMC osteoarthritis patients will have subclinical carpal tunnel syndrome, and this looks at cross-sectional area here as a technique to diagnose carpal tunnel using ultrasound, and that cross-sectional area at the wrist crease and under the transverse carpal ligament versus 10 centimeters proximal. So a very good idea to rule out subclinical carpal tunnel either through this method or Phelan's or Tennell's. And if carpal tunnel is present, we tend to perform platelet lysate hydrodissection, which is a separate video, but we're going to focus just on the block here. So median nerve block, general comments, again, use small needles, 27 gauge or 30 gauge. If you cannot see and track a 27 gauge or 30 gauge needle, then you really got no business doing hand work. Do not use a 22 gauge needle in the hand. I think that's malpractice. There is absolutely no rationale to use a 22 gauge needle in the hand. These structures are very tiny, and some of these nerves and nerve twigs are very tiny. And if you run into them with a 22, you're going to cause nerve damage, so please don't do that. Again, image the median nerve on short axis and place the needles on long axis almost horizontally so that you can see these small needles. So what does this look like? Let's take a look at a video I did a while back. And basically you can see off to the left there, you can see a 30 gauge needle. You can see that I'm trying to use the fluid to provide a little bit of distance between myself and the nerve, so you can see the bottom part of the median nerve peeling off there. For scale, that's about the size of a pea. So this is very fine work. I'm now coming underneath the nerve to attempt to halo the nerve, and so that I can make sure that I've got 360 around the nerve. So radial nerve block. Now, we started out, obviously, with anesthesia, hopefully if we did everything correctly, at the base of the thumb, and now we need anesthesia in this area as well. Now, you can try to block the radial nerve at this level, but there are just too many tiny branches. Much better to block it about 10 centimeters proximal to there before those branches occur. So again, at that point, you can more accurately see the radial artery nerve vein complex. And from there, you can target that complex, even though the nerve, even at that point, is very small. So this is what it looks like. Here's the superficial radial nerve. This is the nerve artery vein complex. So my focus is going to be haloing around, so underneath this and above this. And again, here, while on the median nerve, you might use 5 to 10 cc's, which would be a lot, even 5 cc's. Here we're only talking about 3 to 5 cc's of anesthetic. This is the step-by-step instructions on the median nerve so that you can freeze this and print this out and use this for your procedure. And here are the step-by-step instructions for the radial nerve. Again, you can freeze frame this, print this out, do a screen capture, and use this when you're doing your first procedures. As far as pearls and pitfalls, half of your time should be spent positively IDing these nerves, about the other half of the time blocking them. And you really need to make sure that you let the anesthetic set up and avoid obviously injecting into the perineum. And approximately 2 to 5 cc's per nerve is adequate. You can go a little higher on the median nerve and a little lower on the radial nerve. You can get in trouble by stabbing the nerve, so that's another reason to keep the needles small. And in all of these, you want to make sure that you're looking at the position of the radial and ulnar arteries. In particular, the median nerve, you've got to look at where those radial and ulnar arteries are so that you don't stick through them as you're getting at the median nerve. And obviously, in the radial nerve, you're going to be looking at that radial artery. So now we're going to look at steps 2 and step 3, capsular and intra-articular injections. So this is hand CMC anatomy. Obviously, our focus here is going to be, again, on CMC. So we're going to focus right here at this joint at the base of the wrist. Now, every once in a while, you'll need to inject the next joint proximal or distal, but for the most part, it's CMC as far as the big money is concerned. As far as capsular ligament anatomy, you're looking at these palmar ligaments here and the radial side ligaments here. That's really where your focus should be, those two ligament sets. And as you know, with CMC joint osteoarthritis on these typical x-rays, you tend to see the metacarpal swing out this way. And that's one of the reasons why we're getting these radial side ligaments. So it's very, very critical that you also consider using hand stress ultrasound. Stress ultrasound is fantastic because you can show the patient what's wrong, and you can even show them progress as you go through. So off to the left here, you can see that joint is not opening very much. Off to the right, you can see the joint opening more. The right is unstable, the left is normal. So recognize that the first thing I always do is to look at the instability of the CMC diagnostically and also record a little clip so I can show the patient later after treatment that this has improved. As far as injection sites, we're talking about 2 palmar and 1 radial, and here's where you go. And on lung axis, we're really going for 3 different layers here. We're going for the tendon layer up here. We're going for the capsular ligament layer here. And we're going for the intra-articular injection with flow going this way. So 1 layer, 2 layer, 3 layers. And you need to be a little bit careful of this recurrent median nerve or recurrent motor branch. Now we're going to be injecting primarily in this area here, so we should be missing it. But it can be very difficult to see, and it's one of the reasons why you really want to stick with very small needles here. 30 gauge 1 inch is usually what I use. The biggest I'll ever use is a 27, because if you twing that recurrent motor branch with a 30 gauge needle, no harm, no foul. But if you hit that thing with a 22, you're going to cause APB atrophy, and you're going to make this patient much worse. So these are the step-by-step instructions for the CMC joint. This is the CMC joint pearls and pitfalls. Be careful not to knock off any osteophytes and severe OA joints. Small structures equal small needles. And there are minimal neurovascular structures here, as we just discussed, but use those small needles. And you can monitor progress by ultrasound stress testing the joint, looking for laxity and improvement in same. So this is a video going to give you a better sense of what's going on here. It's about 12 minutes long, but it does put all the pieces together. You may have to turn down your volume a little bit because this could be a little loud. There's one area that's a little soft, so you may have to turn it back up for that. But I'm going to run the video here and show you what this is all about. We're going to do a CMC injection on this patient. You can see how he's supine. His hand is on the hand board here. We're going to have his hand palm up. And we'll start with the median nerve block, and then we'll do a radial nerve block as well to try to get good anesthesia, and then we'll go from there. So you can see I've got a small needle here, a 30 gauge 1 inch. You can also use a 27 gauge. The max I use is a 25 gauge. And really, if you're having to use a 25 gauge in order to see your needle, you're probably not at the point where you should be doing any hand work. So 27 or 30 is the way to go. I've got some anesthetic here. I'm going to find the median nerve first. So I'm going to move proximally. You can see the median nerve comes down on the screen. And then as I move distally, the medial nerve will take its position where superficial will move up on the screen. So that's how I can differentiate from those tendons on either side and the median nerve in the middle. So I'll start my median nerve block about right here. And Jamie will give me a little bit of cold spray. And a little bit of poke mark. So I'm going to find my needle there. Come above that tendon, just underneath the transverse carpal ligament. And I'm going to start injecting some fluid to perform some hydrodissection and also to give my needle a little bit of wiggle room there. And I'm right above the nerve now. And again, I'm pushing the nerve away from me with the fluid, which is giving me a nice buffer and keeping the nerve well away from my needle. So again, I'm right on top of the nerve here,
I'm going to inject just a little bit more right at that interface to peel the top of the nerve off. And now I'm going to come a little bit deeper. This is where it gets a little trickier. I've got a 30 gauge needle, so I'm going to go underneath that tendon. And my needle imaging is going to get not as great here because I'm at a steeper angle, but I can see my needle tip. And certainly I'm injecting quite a bit of fluid, so I can see where I am based on that as well. I'm underneath the nerve right now. Mark, do you feel anything?
No.
Okay, see my needle there, underneath the nerve. I'm going to peel the nerve off on the bottom, and that'll get me to 360 around that median nerve. So that should start to give me some anesthesia. Now I'm going to go to his radial nerve, and I'm going to bring his hand more in this position. And just massaging in some of the anesthetic for the median nerve. And I'm going to find his radial artery. So I can see his radial artery there. I've got it approximately in the center of the screen. And the radial artery and nerve complex can be much harder to identify if it splits as you get more distal. So it's usually much easier and less complex to pick it up more approximately about right here. Going to come in on this radial side here and a little cold spray. Some on the radial side, which, yeah, would be great from there. A little poke. You can see my nerve there, or my needle there on the screen. I'll be injecting a little fluid as I go. Again, a little 30 gauge, 1-inch needle. And the compartment is right above my needle there. So I'm going to peel off on the bottom here. We got the whole area. And now I'm going to come above, I'm going to try to go above that tendon that I see. Right there. And I'm going to try to come above that nerve artery vein complex now. And peeling it away from the top. Right there. Okay, and that's that. Okay, so I've got a median nerve block in, I've got a radial nerve block in, and that's to try to provide as much anesthesia because I'm going to want to do an injection on the volar side as well as an injection on the radial side. So I'm going to be injecting both places, so hopefully we've got good enough anesthesia. So we're going to look at the CMC joint here. We're going to try to determine just its laxity. So I'm imaging long on the joint, and you can see the CMC joint has got major laxity there. You can see it opening like a mouth, if you will. And it shouldn't open like a mouth, it should slide. So the fact that it's gaping right here shows that he's got instability. Additionally, you can see some of the synovial fluid coming up so that the joint's a little bit effused. So we have CMC instability, and this CMC stress test is a great way to look at serial procedures and make sure that you're actually getting really good results in tightening down those ligaments. So we're going to work first on these capsular ligaments here, and Mark can tell me if this is tolerable. You feel that? See my needle there, and I'm going at this point for these capsular ligaments on top of the joint. I don't want to see in this portion of this procedure much going into the joint at all. In fact, I want to avoid it because I want to put my higher dose PRP into the joint and my slightly lower dose PRP into this, these capsular ligaments. So you can see me here just working the capsular ligaments little by little. And I'm going to move a little bit distally here in the field of the poke. And you can see my needle there. And again, I'm working not only capsular ligaments, but also some of the tendons in this area, which can develop a tendinopathy all by themselves. So, gives you a sense there of what I'm doing. And then I'm going to move over just a little bit in this direction and see if I can work on these here. So you can see again, these small capsular ligaments is what I'm focusing on. Mark, is that painful? No. Trying to avoid intra-articular. Okay, so now we will finish off the ligament portion by doing the radial side capsular ligaments. So as you know, one of the bigger things that you, just keep it on the screen. Okay. As you know, one of the bigger things that you get is you get instability laterally on x-ray. So you'll see that classic lateral translation in a CMC joint. You can see he's got instability here laterally as I stress this joint. So he's got exactly what you would see on those x-rays. Maybe he's a couple years away from it, but eventually he's going to get lateral displacement here. So we'll poke. And you can see my needle here coming in from the left. And again, I'm going to work on those lateral capsular ligaments. Again, my focus is not intra-articular here. In fact, to the extent I see intra-articular, that's not what I want. What I want is I want to focus on this capsular ligament complex right here where I'm injecting right now, above the joint, staying out of the intra-articular joint. I'm working it across the entire joint from distal to proximal. A little bit. So, done the volar ligaments, I've done the radial ligaments. Now I'm going to focus on one final intra-articular injection. Now we tend to use much higher concentrations within the joint. So this is a 14x or 14 times over the baseline leukocyte pore, and all of this has been leukocyte pore PRP. And I'm going to inject intra-articular now. Now this joint doesn't hold a lot, so you can really reduce patient discomfort by not overloading the joint. I wouldn't put a full cc in here. I would tend to go quarter to half cc at this point to finish this injection intra-articular. Okay, we'll poke 1, 2, 3. Okay, intra-articular right there. You can see it going intra-articular. And again, just a quarter to a half cc, you don't need anything more. If you put too much volume in any small joint, whether it be a CMC or a first MTP in the foot, and you get any type of effusion afterwards, you're going to make the patient very, very uncomfortable for you. So that's it. We're done. We've done the nerves. We've done the capsules. Now we did the joint, and that's all complete. So just want to ask Mark about his discomfort during this procedure. Mark, what did you feel? What are you feeling now?
I felt a little poke. It's numb, so I felt really no pain, no discomfort whatsoever.
Okay, so as you can see, successful procedure there, and we'll wrap this up. So thanks for watching. Have a great day. Obviously, there's a lot more to learn in level 2 hand and wrist, all that great stuff there. So avail yourself of all those other videos, and we'll sign out here.